Hello, I'm Richard Young, your host with Facundo Batista and Lena Fayan for MIT's course on SARS-CoV-2, COVID-19, and the pandemic. We've now heard experts discuss the pandemic, the coronavirus, and our immune response to it. When I think about COVID patients, the hospitalized people infected with a virus new to humanity and exhibiting a wide range of organ system functions and dysfunctions that can appear suddenly and defy treatment, I think of the healthcare providers as the true heroes of the pandemic. Heroes are people who are noted for special abilities, courageous acts, nobility of character. These people are saving the lives of our mothers, fathers, sisters, and brothers. One such hero is speaking to us today. Dr. Victoria Clark is a physician scientist, a person who has both MD and PhD degrees. Her PhD is in neuroscience, and she's a neurosurgeon at Massachusetts General Hospital. For full disclosure, when she is not treating COVID patients and conducting brain surgery, she spends part of her time in my laboratory at Whitehead and MIT, attempting to discover new solutions to brain cancer. Dr. Clark, thank you for telling us about the patient.
All right, well, thank you, Rick, for that incredibly generous introduction. You know, I hope one day that my resume is as distinguished as the other lecturers in this series. But the reality is, if you or your mother or your newborn are sick enough that you end up in a major academic medical center, it will be someone like me, a resident or a fellow, who straps on an N95 for a 24-hour shift and watches you like a hawk. And it's from that perspective that I'm absolutely honored today to talk to you about the patients with COVID-19. As is the tradition for medical lectures, I want to start by saying I have no financial disclosures or conflicts of interest. I do want to emphasize that the lecture content is not medical advice. So if you have symptoms concerning for COVID-19, you should call your doctor. I will mention some specific medications that are under investigation in clinical trials, but I am not endorsing the pharmaceutical companies. And finally, although I am a doctor at Mass General Hospital, I am not speaking on behalf of them today. So when I reflect on the pandemic, there's really three fundamental concepts in the delivering of medical care that I think have been highlighted. That is the science of medicine, the art of medicine, and the practice of medicine. And what I mean by the science of medicine, it's just like the other disciplines in biology. Medicine is based on observations about patients, which are obtained through history, examination, and testing, which in combination are used to generate a hypothesis about the underlying disease process and how to best treat it. I really do think this was exemplified at the very origins of the COVID-19 pandemic, when Dr. Ai Fen, the 33-year-old director of the Wuhan Central Emergency Room, began treating several patients in her emergency room with atypical pneumonia. She was noticing this pattern. On December 30th, the lab report for her second patient showed that the pneumonia was consistent with SARS coronavirus, and she immediately began sounding the alarm that there was concerns for a SARS-like viral pneumonia and shared the report with other doctors. This is the perfect example of the doctor as scientist. And we'll also be seeing other examples of the doctor as scientist as we go through some of the clinical trials that are informing our treatment decisions. Next is the art of medicine. At the edges of medicine, there is a paucity of quality data to make clinical decisions, yet the patients still require urgent treatment decisions. And in this situation, clinical judgment, experience, and collaboration become critical. So on the left, we can see a normal chest x-ray. So where this black is, that is normal. That's what it looks like when air's in the lungs. And then you see on the right is an example of a patient who has COVID-19 ARDS, which is a disease process we'll focus on today. And you can see in contrast, there's now all these white little patches everywhere, which is consistent with fluid filling the alveoli sacs. And the question is, how did the ICU doctors know what to try for COVID-19 ARDS in March? This was a novel coronavirus. This had never been seen before. Well, the truth is they didn't know exactly how to treat a viral pneumonia caused by SARS-CoV-2, but they had decades of experience in treating ARDS caused in the context of other viral pneumonias. And so they knew exactly where to start, even though there was not specific evidence behind the treatment of COVID-19 ARDS. And then finally, there's the practice of medicine, the humility to recognize that medical knowledge is incomplete, that the tools are imperfect, and patient factors are infinitely complex. In the Stop COVID trial, which is a large 65 center trial in the United States, one of their findings was that there was marked variation in the administration of different medications. So for example, in some hospitals, 0% of the patients received the medication tocilizumab, and then in other hospitals, it was closer to 60%. And with this variation came marked variation in patient mortality. I find this graph extremely striking. What it means is if your mother is taken on an ambulance, all her other medical factors the same, to hospital A, she had a 5% chance of mortality. But if it took her to hospital B, her risk of mortality, all other factors the same, was over 80%. With that, I'd like to get into the body of the lecture today, which will be divided into 3 parts. The modern way to teach medical school is to have everything case-based. So I'd like to start out by discussing a case study of a 47-year-old gentleman who came to Mass General Hospital and was treated for severe COVID-19. I'd like to then move on to the spectrum of COVID-19 patients, and then finally to discuss the evidence base for treatments. Okay, so to get into our case, there's a 47-year-old gentleman who was overall pretty healthy. He did have a history of high blood pressure and asthma. He presented us with several days of fever and shortness of breath. And then after going to Mass General Hospital, he rapidly decompensated. So on the first day of hospitalization, he was transferred to the intensive care unit, required placement of a breathing tube, and his test results came back positive for COVID. This X-ray series is not from our patient, but I do believe illustrates the progressive chest X-ray findings that are typical of severe COVID-19. So on the left, you can see at the base of the lungs and on both sides, it's white. While the rest of the lungs are basically black, indicating normal aeration. This sign, the bilateral lower lobe whiteness, the infiltrates, while is not specific for COVID-19 pneumonia, is consistent. This is the most common pattern that we saw. For this patient, progressively, there was increased white space until finally, there was so much white space in the lungs that the patient required an endotracheal tube, which you can also see on the X-ray. So at this phase, it's considered to be bilateral, so both sides diffuse, meaning affecting multiple lobes of the lungs. And then those white little spotches are actually in the alveoli. And this is consistent with ARDS. One thing I want to emphasize, though, is ARDS is not just bad pneumonia or progressive pneumonia. It is, in fact, a distinct but related disease process. So the full name for ARDS is acute respiratory distress syndrome, and I liken it to drowning on dry land. So it is an inflammatory lung injury syndrome, but it is not specific to COVID-19, and it's in fact not specific to pneumonia. There are over 60 known inciting causes. The inciting causes typically, for example, a large trauma, happen around 8 days in advance of that lung flooding X-ray picture that we just saw. And that first phase is called the exudative phase. And it is characterized by innate immune cell mediated damage to the barriers that separate the blood vessels and the alveoli. And when this occurs, there is flooding of the alveoli with fluid. Now, later stages are characterized by healing of this barrier and then fibrosis as well, but the edema does absorb over time. So the mortality of ARDS is very high. It's around 30 to 40%. In the context of COVID-19, we understand that ARDS, which is very common, actually fits into what we recognize as sort of this two-peat disease process, where in the first sets, in the first couple of days, patients can be asymptomatic or begin to show symptoms. And this is a reflection of the damage that the virus is doing directly to cells. But many people, most people do get better, but a subset of people go on to have a severe host immune response to the viral infection that is in fact more severe than the direct damage done by the virus. And ARDS falls into this later secondary hyperinflammation. And there are other disease processes that are associated with this cytokine storm, including failure of other organs and sepsis. In terms of treatments, ARDS has been recognized as a phenomenon for over 50 years, and there are decades that have gone into optimizing the treatments. A pretty complicated algorithm, but the big picture is the strategy is to minimize additional lung injury, to optimize the oxygenation of the dry alveoli, for example, by proning the patient, having them on their bellies for at least 16 hours a day. And then more or less riding it out through the exudative stage until the lungs heal themselves and reabsorb some of that fluid. In fact, there are no specific treatments or drugs for ARDS. The mainstay is this supportive care. And it's important to discuss ARDS because, in fact, it is the most common cause of death in COVID-19 patients. In this trial, which focused on critically ill COVID-19 patients, 92.7% of patients who died of COVID-19 had respiratory failure. And if you look at the length of time these patients required mechanical ventilation, it was extensive. So on average, even the survivors spend 11 days mechanically ventilated. And this has very serious implications for our healthcare system. And you probably remember in the spring, the focus was flatten the curve, flatten the curve. Well, this is what they're referring to, is the fact that if COVID patients are spending 2 weeks on the ventilator, there are only so many ventilators. There are only so many ICU beds and only so many nurses and respiratory therapists who are capable of taking care of these patients. And the big concern was that our healthcare system would be overwhelmed to the extent that COVID patients were going to be going on ventilators faster than they were coming off. So back to our case study. So our patient ended up having a very severe hospital course. So at the top, you can see the days of hospitalization. On the left, you can see the different types of medications sort of grouped up. So paralytics are used for part of the treatment of severe ARDS. You can see the patient was on multiple sedations and at some points required 3 different very powerful medications that can only be administered in the ICU called vasopressors just to keep the blood pressure up to a normal level. This is commonly seen in shock. But the patient began to get better from a lung perspective. So you can see by day 33, most of the medications are peeling off. He's no longer requiring the multiple pressors. The sedation is coming off. He's in a lighter ventilation setting. But this patient, even though his lung function is improving, he was not waking up neurologically. And in the bottom, here you can see he remained in a vegetative state. And this is in the absence of clear explanation based on the brain imaging that he had. And in fact, it was not until day 61 that this patient woke up and began to follow commands. To me, this case illustrates how complex the care of COVID-19 patients can be, how severely ill they can become, the type of intensive care they require, and the length of time they spend on the ventilator. And then also highlights the mystery. We don't know why a 47-year-old man got this sick to begin with, and we certainly don't know why it took him 61 days to wake up in the absence of huge structural brain damage. Moving on, I would now like to talk about the spectrum of COVID-19 patients. So when Rick very kindly asked me to give this lecture, the working title was COVID-19, the Patients. But upon reflection, I realized that, in fact, there is no one COVID-19 patient. Of course, it's a spectrum of patients. It affects all humans at all phases of development. And I want to start by focusing on the pregnant patient and fetus. So pregnancy is a time of great metabolic change for the woman. For example, the cardiac output increases 50%. There are massive changes in the blood dilution. It's a hypercoagulable state. The fetus compresses the diaphragm, changing respiratory mechanics. In addition, the immune system of the pregnant woman is altered in order to prevent attacking the fetal non-self cells. From the fetus perspective, we already know that there are viruses that, if the pregnant patient acquires them, can be passed through the placenta and can affect the fetus. In fact, in this example, on the left, we see a normal infant brain. And on the right, you see an example of infection of cytomegalovirus. So in this 1-day-old infant, you can see that the ventricles are grossly dilated. So this fluid space here is much larger than here, consistent with hydrocephalus. And also there is a lot of calcification throughout the brain. This is grossly abnormal brain with long-term developmental implications. And the question is, can SARS-CoV-2 be passed through the placenta to the fetus? Does it cause developmental impacts, such as some of the other viruses do? Well, not too surprisingly, based on the risk factors and all the changes that I just mentioned, pregnant women, in fact, are a high-risk group for severe COVID-19, with a higher risk of needing ICU admission and ventilation. Fortunately, mortality is not significantly increased in this group compared to age-matched non-pregnant women. The odds of preterm delivery were 3 times higher for COVID-19 positive women, and the risk of neonatal ICU admission was over 3 times higher as well. In terms of vertical transmission, so passing the virus from the pregnant patient to the fetus, it has been documented. So there was a case report of a 35-week pregnant woman. She ultimately needed an urgent C-section for fetal compromise. So during the C-section, the obstetricians were able to sterilely harvest amniotic fluid, the placenta, and also test the blood of the neonate. And they all tested positive for SARS-CoV-2. Here you can see the staining along the placenta, which is positive for SARS-CoV-2 compared to control. MRI brain later performed on a neonate showed white matter injury, which you can see here with these little dots. The thought being that this was likely due to vasculitis, inflammation of the vessels in the brain because of SARS-CoV-2 infection. Now, while vertical transmission has been documented and is apparently possible, it fortunately appears to be very rare. So in a study out of New York, 0 of the 71 infants born to COVID positive pregnant women were positive for COVID. And However, it was noted that the placentas for these pregnant patients were abnormal in the COVID positive patients, and specifically they had blood clots and they had abnormalities in the perfusion of the fetal vessels. Now we'll move on to discuss manifestations of COVID-19 in children. And as you can imagine, there are vast developmental differences between a 10-month-old and a 5-year-old and a 17-year-old. The central mantra of pediatrics, the thing that they drilled in our heads over and over in medical school, is that children are not just small adults, that there can be different manifestations of disease processes, meaning a child and an adult can have the exact same viral infection and have very different symptoms. In part because the immune system of the child is in a state of development. Other organs are also in state of development, for example, the liver and the kidney. So there are different pharmacodynamics. The way that you administer drugs is different in children, and it's different in children of different ages. And there's also the potential for the disease process and or toxicity related to treatments to have long-term developmental implications in this very vulnerable group. This data is from COVIDNet, and it's the cumulative COVID-19 hospitalizations by age in the United States. So they have split children into 2 groups by age, 0 to 4, the yellow line at the top, and 5 to 17 in the bottom. And you can see the 0 to 4-year-olds have actually nearly twice as high of a rate of hospitalization as the 5 to 17-year-olds do. However, both of these groups dwarf in comparison to adults, which is defined here as grouped together as just greater than age 18. So while there are differences in disease severity between younger and older children, in all cases, it does seem that children are hospitalized at a much lower rate compared to adults. For the children who do get hospitalized and are sick enough to end up in a pediatric intensive care units, what we have learned is that these children are very sick. So 38% of them in this study did require mechanical ventilation. But fortunately, they did well. Only 4% of the patients had mortality at the time of follow-up. Now, this is critical illness due to primary COVID-19. But what we're learning is that there can be a secondary illness, which is termed multi-inflammatory syndrome in children, or MIS-C. So this is a hyperinflammatory syndrome, has a range of symptoms, and it occurs in children in a delayed fashion after SARS-CoV-2 infection. In fact, some children may never have any symptoms of SARS-CoV-2 infection at all. And then around 3 weeks later, they begin to develop this very severe MIS-C symptomatology. And it is distinct from the adult hyperinflammation that we discussed with the double peaks, which is more of a progressive infection and typically occurs much earlier. So the patients don't get better and then weeks elapse and then they have this hyperinflammatory states like they do in children. So the constellation of symptoms that is associated with MIS-C includes a characteristic rash. On the right, you can see an example of a small child with that rash, conjunctivitis, and abdominal pain is also a major manifestation. But perhaps the more concerning manifestations are those of cardiac, which is seen in over 80% of patients and frequently leads to shock, requiring vasopressor support in order to keep the blood pressure up to a sustainable level. There is another disease called Kawasaki disease, which is a medium vessel vasculitis that we can also see several weeks after a viral infection. And MIS-C does have overlapping features with this disorder, but it is distinct in terms of the inflammatory cytokines and the T cell subsets. The most frequent organ systems in MIS-C were GI, primarily abdominal pain, but also diarrhea, as well as cardiovascular. And these patients are sick. So 80% of the patients with MIS-C do require ICU level care. Fortunately, their mortality is low at 2%. Finally, we'll discuss the manifestations of COVID-19 in adults. So here I have further broken down that COVIDNet data to stratify the adults into 3 groups. So you can see that age is a major risk factor for severe COVID-19 and death. And in this chart from the CDC, they have grouped them basically by decades, and using the 18 to 29-year-olds as a comparison group, you can see, for example, 5 to 17-year-old children have a 16 times lower risk of death from COVID-19 compared to the comparison group, while 85-year-olds and older have a 630 times higher risk of death. And that is very profound. I cannot think of really another illness where the discrepancy is that severe and that closely related to age. It is also clear that racial and ethnic minority groups are at increased risk for COVID-19 hospitalization and deaths. For example, American Indian or Alaska Native people have a 2.8 times higher cases compared to white non-Hispanic people, and have a hospitalization rate that's 5.3 times higher. Black and African American people have a 2.1 times higher risk rate of death compared to white non-Hispanic persons. In terms of trying to figure out what are the characteristics of the people who do become critically ill enough that they die, one such study is the Stop COVID study, which was a 65 center cohort study that looked at thousands of patients across the United States. And the primary outcome was in these patients who are sick enough to be in the ICU, how many of them died and what were the major risk factors. So you can see the baseline characteristics straight off the bat. The majority of these patients were male, and the predominant symptoms were cough, shortness of breath, and fever. But all of these symptoms only occurred in the 70% range. So there really was no one symptom that was present 100% of the time. And these symptoms, in fact, are very non-specific. They were able to use their data to construct this chart of temporal changes in acute organ injury. So we can see early in the course, the patients were hospitalized. Some of them required ICU admission right away. Next up, we see respiratory failure and ARDS around 8 days after symptom onset, consistent with that double curve. But there are other organ systems that it's clear become involved slightly later. The major organ system being involved is the heart. So acute injury to the heart, inflammation of the heart and the heart lining, as well as heart failure, all occur right around the time of this hyperinflammatory response. Slightly later, it's very frequently to see damage to the kidney. AKI stands for acute kidney injury, as well as shock, the ability for the patients to maintain their own blood pressure. One thing that we frequently see in COVID-19 patients is coagulopathy, specifically the tendency to form blood clots. And from this coagulopathy, we frequently can see a thromboembolic event, for example, a stroke. Additionally, later on in hospitalization, so if a patient has had a breathing tube, let's say for 10 days, then we can also start to see morbidity associated with being in the hospital. So, for example, getting a bacterial pneumonia on top of the COVID-19 viral pneumonia. Additionally, it's clear that the liver is involved and that you see elevations and derangements in the liver enzymes. And then finally, unfortunately, a subset of patients die on average 16 days after symptom onset for severe COVID-19 in this study. So looking into these 28-day mortality outcomes, about a third of their patients who were sick enough to go to be in the ICU, that was the study criteria, they died within 28 days of ICU admission. Slightly more than a third of them were discharged alive within 28 days, and slightly less than a third of them remained hospitalized 28 days later. And I want to again emphasize that this impresses on how lengthy the hospitalizations can be for patients with severe COVID-19. And there are only a limited number of hospital beds and of ICU beds in the United States of America. And this study showed that nearly a third of patients are still hospitalized a month later. The factors that they found to be independently associated with death included age. So here in their study, age over 80 was 11.15 times higher odds ratio of death. Other factors such as coronary artery disease. But one very interesting observation came from the fact that the number of ICU beds in the hospital actually greatly impacted the risk of mortality. So if the patient, all other medical comorbidities controlled for, was admitted to a hospital with a small number of ICU beds, so less than 50, their risk of mortality was 3.28 times higher than if they had been admitted with the same symptoms to a hospital with a high number of ICU beds. And this is not to berate smaller hospitals, it's more to emphasize the fact that there are disparities in healthcare. And as we approach a new surge, it will be important for hospitals to share strategies to try to level out this discrepancy. So this study and other studies have made it clear that there are some risk factors, clear risk factors that for severe COVID-19, but there's a clinical mystery. Why do some patients with absolutely no known risk factors still get severe COVID-19? That's not totally clear, but there is some emerging evidence that the type 1 interferon response is altered in a subset of patients, and that this can predispose them to severe pneumonia. So as a quick review of topics that have been covered by other lecturers, infected cells produce type 1 interferons in response to a viral infection. The interferons act in an autocrine and paracrine way to trigger the interferon stimulated genes, which go on to trigger the immune system, for example, for natural killer cells to lyse the infected cell, and also to facilitate the production of antibodies by B cells. In pair of back-to-back studies in Science, it was found that autoantibodies against type 1 interferons were found in 14% of patients with severe COVID pneumonia, and that the majority of these autoantibodies were found to be neutralizing in vitro. And interestingly, the vast majority of patients who had these autoantibodies were men. So this may in part explain the male predominance that we see in severe COVID-19 patients. And a separate study looked at germline variants, and they found loss of function variants in the type 1 interferon immunity. So in the genes highlighted in green boxes here, were found to be present in 3.5% of patients. And these were patients who, although they apparently had defective type 1 interferon mutations, they had never had a clinical issue with fighting viral infections before, and it was unmasked specifically by SARS-CoV-2 infection. And for the patients who they had serum collected, they found that in fact the interferon alpha levels were low in these patients. So as a summary for the spectrum of COVID-19 patients, pregnant patients are at a high risk for severe COVID-19. Children are at a lower risk of severe COVID-19 compared to adults, but they can develop the hyperinflammatory condition MIS-C. The median age of that is 8. That advancing age and medical comorbidities increase the risk of severe COVID-19 in adults, and that there is increasing evidence for altered type 1 interferon response as mediating COVID-19 severity, at least in a subset of patients with severe COVID-19. So finally, I wanted to spend some time talking about evidence-based treatment. So as we began the lecture with a case, continuing in that tradition, I would like to discuss another case. So a hypothetical 74-year-old man with a history of hyperlipidemia, very mild heart disease, borderline obesity, presented with fever, mild cough, nasal congestion, and fatigue, was found to be COVID positive, and then the next day required hospital admission after he developed a supplemental oxygen requirement. Now, this hypothetical 74-year-old man had access to the smartest doctors in the world and unlimited healthcare resources. And the doctors came up with the plan of 5 doses of remdesivir, 10 doses of dexamethasone, and 1 dose of an investigational antibody cocktail. Our hypothetical patient did not receive hydroxychloroquine, tocilizumab, or convalescent plasma. And the question is, what is the evidence supporting this COVID-19 treatment plan? Well, whenever you're thinking about evidence-based treatment, there are the patient factors, and then there are the treatment factors. So what are the risk factors that the patient has for developing severe COVID-19? Clearly, age, male sex, obesity, and the mild heart disease all predispose for severe COVID-19. How sick is the patient currently? Well, he required supplemental oxygen, which does put you in a different category of patients. By definition, if you require supplemental oxygen, it is considered to be severe COVID-19. And then where do we think that he is on this double curve? Well, we know that the symptoms just began a day or 2 prior to hospitalization, so likely early in this curve. And that's important because if a patient is actively fighting off a virus, you would not, for example, want to give something that would suppress the immune system. But if you think the patient is later on in the hyperinflammatory phase, then, the horse is out of the barn. Antivirals are not going to do a lot of good at this point, but instead the focus really should be on modulating the immune response. And then there's also treatment factors. So what is the level of evidence that is available? Randomized controlled trials, case reports, animal-only studies. How available is a potential medication? Is it only available through clinical trial? Has it received emergency use authorization under the FDA? Or is it something that is found on every shelf in every pharmacy in the world? Additionally, it's always important to consider the specific side effects as they apply to your patient. So what is the evidence base for remdesivir for COVID-19? Remdesivir is an inhibitor of the viral RNA-dependent RNA polymerase, considered to be a delayed chain terminator. The cost is around $3,000 for a course of 5 doses, which are administered IV. Currently, there is an emergency use authorization for hospitalized adult and pediatric patients. And in terms of availability, the manufacturers anticipate the ability to have 2 million treatment courses available by December 2020. The ACT-1 trial was a double-blind, randomized, placebo-controlled trial, so that's the highest level of evidence that we have in medicine, in over 1,000 COVID-19 patients. And what they were studying was time to recovery. So not mortality was not the primary endpoint, but how fast did the patients recover? And they found that the patients who received remdesivir had a faster recovery time, a median of 10 days versus 15 days for placebo. But when they broke people down into severity of disease, the most profound effects were actually in the patients who were only receiving supplemental oxygen, but were not sick enough to be, for example, mechanically ventilated or receiving what's called high flow nasal cannula. Additionally, the patients who benefited the most from remdesivir were youngest patients, so less than 40 years old, and those who were early in their symptoms. So the way I think of it is the potential group that is possibly benefiting from remdesivir would be those in this early peak. So those who are still undergoing the active viral response, which makes sense because it is in fact an antiviral. Now, just to show how quickly evidence changes in a pandemic, actually after I already made those slides, the WHO Solidarity Trial Consortium published a preprint which showed in their group, which is a larger cohort of 5,000 patients, that there was no benefit to remdesivir. And they actually go through here and they do specifically bring up, the ACT trial, which again, there was a benefit for low flow oxygen, but that did not bear out in the WHO Solidarity trial. Now, this is still awaiting peer review. There were some differences. For example, in the WHO Solidarity group, they combined together patients with high flow oxygen and low flow oxygen, so that may be masking some of the effect. But I think the big picture is that, remdesivir may have some benefit, but it really needs to be in a select group of patients. And it's most likely to be the ones who are earlier in their treatment course and are just sick enough to need a little bit of oxygen, but are not so sick that they require mechanical ventilation. So the final word on that is TBD. Next, we'll discuss the treatment of dexamethasone for COVID-19. So dexamethasone is a glucocorticoid, and it is a very potent anti-inflammatory steroid. It is extremely cheap. The administration can be either oral or intravenous. For COVID-19, the trials have used it a single dose for 10 days. It is considered to be approved for off-label use, and it is more or less freely available. In fact, there are over 1 million prescriptions a year in the United States alone for dexamethasone. One of the first very convincing lines of evidence that dexamethasone would be effective came from the recovery trial, which is based in the United Kingdom. And they studied mortality. And they found that dexamethasone use in COVID-19 patients as a whole group improved 28-day mortality from 22.9% to 25.7%. But when they again broke down the patients in terms of their oxygen status, this was much more pronounced in the sickest patients. So the patients who were sick enough to require invasive mechanical ventilation, they clearly had a benefit to dexamethasone. Patients who had supplemental oxygen requirements also had a statistically significant benefit. But the patients who were basically breathing on their own, were not requiring supplemental oxygen, trended to do worse with dexamethasone treatment. Additionally, patients who had their symptoms for a longer duration of time, so greater than 7 days, were also more likely to show benefit. So you can think that the group that would potentially be benefiting more from dexamethasone would be that group who has launched into the hyperinflammatory response. And ideally, people who are early in that phase, so that you can block that progression to severe disease. And then finally, I want to discuss one investigational antibody cocktail. There are several right now that are being developed by different pharmaceutical companies. Regeneron CoV-2 is the combination of 2 monoclonal antibodies against the spike receptor binding domain. You can see here sort of like Mickey Mouse ears. They the nice thing or the design of these two monoclonal antibodies is that they bind to separate regions of the receptor binding domain and do not compete against each other. The cost of this treatment is unclear. It's given as a single dose. Right now, it is for compassionate use only. So this is not something that you can ask your doctor for. They have applied for an emergency use authorization. That application is pending, but would make it more widely available in the United States. But even if that EUA is approved, there are currently only 50,000 doses that are potentially available. In terms of the clinical evidence, right now, it's only via press release from the drug company that created the cocktail. And the study has also been done in non-hospitalized patients. So this does not reflect the data for patients sick enough to be in the hospital, patients who are intubated, for example. But they did report that for their non-hospitalized patients with a high viral load, so greater than 10 to the 7th copies, that the cocktail resulted in a 99% reduction of viral load compared to placebo. And they furthermore noted that, patients can be divided into two categories. So there's a category of patients who make their own antibodies appropriately to the virus, and that these patients did well. They had a relatively quick recovery time, and they did not necessarily gain a large benefit from this investigational antibody cocktail. But that there's also a subset of patients who, for whatever reason, do not mount their own antibody response. And in that subset of patients, the seronegative patients, they reported that the administration of this antibody cocktail decreased the recovery time from 13 days to 6. So there are ongoing phase 2 clinical trials in hospitalized patients for this investigational antibody cocktail, and it all awaits peer review, but it is preliminarily promising. So the group that would potentially be benefiting from this antibody cocktail is, again, the early group that is actively fighting off a viral response. Okay, well, that really concludes the lecture for today. We talked about case study of a 47-year-old with severe COVID-19, the spectrum of COVID-19 patients, and as well the evidence-based treatments. I would like to give some acknowledgments. I am eternally grateful to Rick Young and the Young Lab, especially Jesse Platt, who has been my co-pilot in weekly discussions of COVID-19 clinical updates, as well as Lena, who is one of my lab mates and facilitated an amazing discussion yesterday in her capacity as TA. I'm also very grateful to MGH Neurosurgery, especially my chair, Dr. Carter, as well as MGH, specifically the president, Dr. Slavin, who through his leadership really did a remarkable job keeping the employees and patients safe, especially when Boston was facing the worst of the surge so far. In the spring, we never ran out of PPE. We never ran out of ventilators. We stayed safe. And for that, I'm eternally grateful. I do finally want to acknowledge the 1,293 United States healthcare workers who have died from COVID-19. Their stories are being outlined by The Guardian in their Lost on the Frontline project. And to emphasize that we are nowhere near the end of this pandemic, that there is absolutely no end in sight. And we all have pandemic fatigue, there's no doubt about it, but we have to continue to do the right thing. We have to continue to protect the medically vulnerable by wearing a mask, socially distancing, and washing our hands. And the life you save may be your own, because the honest truth is our knowledge is incomplete. There are plenty of patients who have no known COVID-19 risk factors who do develop severe COVID-19. And with that, I'm happy to take any questions. And once again, it has been my absolute honor to speak with you today.
Thank you very much, Victoria. There are a large number of questions. I'm going to take them from some of the broadest issues. So, you mentioned that age is a major risk factor for severe disease and death, more than you're aware of for other infections. Why do you think this is so? Could it have something to do with the broad range of infection of organs that become involved?
Well, in the spring, especially when the sort of the first peak hit the United States, um, what is unfortunately clear is that many nursing homes were very affected. So the virus seemed to just circulate around these nursing homes before we had a clear idea of how it was transmitted, before the healthcare workers there had appropriate PPE. So a lot of the drivers, especially in the patients who are greater than 85, came from that earlier time in the pandemic, um, before it was clear what was going on. So, for example, in Massachusetts, I think over 50% of patients who have died, um, their deaths were associated with being in a nursing facility or a long-term health facility. So I think it's a combination of how easily transmitted the disease is, um, and how we were basically caught off guard in the spring, that has driven at least a subset of that. The study that I mentioned that showed that the type 1 interferon autoantibodies were higher in men, they were also higher, statistically higher in patients aged 65 and older. So that may also be playing a role to contribute to disease severity as age increases.
There are many questions about the impacts of the virus on various tissues. One from Dana is, can you give more insight on the long-term neurological effects of COVID?
It's challenging. So I guess one way I will address this is with the so-called long haulers. So you may have heard of patients who weeks and months after resolution of COVID-19 are complaining of brain fog, is what they call it. And it's really not clear what that is, although that is technically a neurologic symptom. One of the things in terms of acutely ill COVID-19 patients that really complicates the assessment of neurologic symptoms is the fact that many patients who are critically ill, whether or not it's with COVID-19, become what's called encephalopathic. So being in an ICU for 30 days is extremely disorienting, especially for older patients. Being intubated for that length of time has effects on the brain. And so it's very hard to pin down which of the neurologic sequelae are actually from or directly related to COVID-19 versus how much of it is related to the critical care administered and required, as well as the length of hospitalization. Whether or not COVID-19 has a neurotropism or can directly infect the brain is kind of hotly debated. There are definitely some case studies that are consistent. So they have documented, for example, viral particles in the frontal lobe of a patient. But overall, that seems to be rare. It does not seem to be the major driver of the neurologic symptoms.
And related to this, Daniel noticed that our 74-year-old patient O2 levels had some dramatic drops periodically. Are those times when neurological damage is most likely to occur?
It's very possible. So the MRI findings on the brains for the patients who do get them, which is not everyone, and you have to think logistically, it's it's very challenging to put a prone patient who is so sick they're on 3 pressors and all these other drips physically in an MRI machine to even get those types of images. So it's certainly not a routine for COVID-19 patients to get MRI brain imaging. But for the ones who do, there is sort of this pattern, this very non-specific pattern of sort of little bit of white matter change, and it's non-specific. It can be, you can get that appearance. It does sort of look like a brain that got cut off of oxygen for a few minutes. It does also, potentially consistent with an inflammatory process in the brain. Uh, so it could be, but there are also other explanations for those brain changes.
And one more question from Ria. If the cases of SARS-CoV-2 do surge this fall, are hospitals more prepared to deal with a large volume of patients?
I think that is a very complex question and certainly on the forefront of most doctors' minds because we are clearly going up and up. Clearly, our testing capacity has greatly improved compared to the spring. So we will be better able to know which patients have COVID-19. And as I mentioned, there are now some clinical trials which do show an evidence base for medications such as dexamethasone, remdesivir, both of which are considered to be the standard of care at this point. And so from that respect, we're not going into this blind. We have better tools, but we still only have a set number of ICU beds. We only have a set number of ventilators. And most importantly, we have a limited number of nurses and respiratory therapists who are trained to take care of these patients and to administer that care. So that is fixed. That has not changed. So we would still be at risk if enough patients get sick enough to have our healthcare system overwhelmed. Although fortunately, we do have more options for them now.
Victoria, I can't thank you enough for this wonderful lecture, and thank you for caring for our family and friends.
It's my honor. Thank you for having me.